So I've split the presentation into two halves. The first half, I'll be talking about Noora's larger intervention, which is much more than our digital solution. And then in the second half, I will delve into the digital piece, including the chatbot and the other chat solutions that we have. This is an often quoted stat around shortages among healthcare workforce. In India alone, 2.5 million, shortage among the healthcare workforce. One of the results of which is doctors and providers, they don't really spend enough time with patients and families. In India, it is about 2.5 minutes per patient. And this number drops to about 45 seconds in Bangladesh. This is a typical ward in the subcontinent. You see a lot of patients, but you see even more family members that throng the wards and the hallways along with patients. And what really happens is that, too often, again, families aren't really acknowledged in that process of care, right? They aren't involved, but at the end of the hospitalization period, they're asked to go home. They're handed over a packet of medicines and asked to take care of the patient. They're anxious, they're confused, they don't know what to really do once they go home. And that was kind of the primary thesis, that we started the organization with back in 2013, which is how can we really tap into this family member who is one of the most compassionate resource that in a hospital, passionate and very involved and incentivized to really help the patient. So how can we utilize that time while they're in the hospital, essentially doing nothing, and whiling time in wards and hallways to really tap into that resource. So we believe, really in the power of family caregiving. And we believe that in healthcare systems around the world, we can really involve them, and with that stat that I showed you earlier, they can really pitch in settings that are really busy. So we convert hallways, that's kind of this program is where we started from. We convert hallways and wards into literally classrooms, right? And there are a lot of components to it that I'll talk about, but just a few pitches before I delve into that piece. And this is kind of, the model in a simplified way, kind of our theory of change as well. It all starts from identifying the behaviors in a particular condition area that we want to shift, right? So it might be breastfeeding for a new mother, it might be wound care for a surgical patient, so on and so forth. Very low risk skills, but skills which, if a family practices, can lead to better outcomes, reduction in complications and hospitalizations post-discharge. From there, kind of through the process of literature review, understanding international and national guidelines, kind of the most important piece comes after that, which is how do you convert that medical information, in a way that the family and the patient can understand easily. In a way which is non-scary, in a way which is very interactive. And that's where we develop engaging tools and materials, from paper-based tools such as flip charts, takeaways, to digital solutions that I'll talk about. And we don't just stop there, right? And then we work with the public healthcare institutions and train their staff, give them the tools that we have developed, train their staff, retrain them, and really hold them through the process of implementation, helping them create that learning environment in a hospital. Hospitals aren't easy settings. Through our experience of implementing this program in about 400 hospitals in India and Bangladesh, we kind of support them in that delivery as well. And once the patient and the family, they get discharged, that's where we continue the follow-up with them through digital platforms such as chat and voice. These are some program areas that we have active programs running in, starting from maternal care to general and medical surgery, to TB, of course, COVID, cardiac and oncology care. So literally across the board, we see this need existing, and especially in some conditions like oncology, where the role of the caregiver is, it goes beyond the medical skills, and a lot of mental health is involved there as well. This is, just broad numbers on our reach. We work with about 7 state governments in India. We just launched in Bangladesh last year. At any given point, we're working with about 3,000 nurses and hospital staff on the ground who are running our sessions on a daily basis, on a weekly basis. We've reached about 2.5 million in India alone. We've published, some peer-reviewed studies as well. It has shown to work, right? So in cardiac care alone, we've seen that there is 71% reduction in post-discharge surgical complications. In maternal care, we've seen 56% decrease in newborn readmissions. And in COVID care, I'll talk about this, when I talk about the digital piece. But we saw 48% reduction in hospitalizations among the, within the group that went through our training. Which was over phone. We've also seen behavior change in terms of uptake on immunizations after some of our training sessions. Just humble bragging here. We've been recognized this year by a school. We are one of the school awardees this year, and as well as this very encouraging gift that we got from Audacious as part of the TED project, which is really allowing us to now scale up beyond India and Bangladesh and into other geographies in Southeast Asia. Just an overview, some things that I've included on this slide, which might be helpful for some of you here. We have campaigns running across 4 condition areas. We target users through the sessions. That's when we deploy and we make them sign up to the digital service. But we are also partnering with the government and kind of getting data from the government databases. And that's kind of the second route through which we sign up users across channels, not just chat, but kind of accessibility is something which is close to us. We do try to kind of offer the service across multiple channels. Languages, some of the metrics that we were talking about in the panel earlier, kind of looking at beyond just reach and exposure metrics, but some of the other ones on message recall and what is the uptake on some of those behaviors as well. So these are now some of the specific campaigns on the digital platform that we have run. So during COVID, we ran home isolation training on the phone. I think the important number to highlight there is the 55% completion rate. When a human is calling you, we saw a much larger uptake among people, and and kind of the willingness to engage with a human on the phone. And this is much higher engagement rate than we see even on chat, for example. But this is definitely higher, resource intensive. These are again for COVID. On the left, we partnered with the government of Bangladesh. Your typical chatbot, which is direct to people, giving them various options to various information. Here, one number I want to highlight is the 8 million people that we reached through our NGO partners. So in India, we took a slightly different approach where we created a chatbot for NGO partners on the ground, and we upskilled them. And through the beneficiaries, through the users that they worked with, we were able to kind of really get that bump in the reach. And we developed kind of the different infographics and kind of collateral for the partners as well. These are some of our programmatic lines, which are much more conversational. Similar to Mom Connect, we have a help desk, and patients and families can ask questions. And that again go through a whole process of translation and then get handled by a team of nurses and doctors. Again, we offer this across both the voice and the phone platform as well. We are much smaller than Mom Connect right now, and that's why they've always been an inspiration for us. Cardiac care, we are seeing higher engagement in cardiac care in comparison to maternal care, probably because it's slightly higher risk, but it's a much smaller service for us. We're just starting out in cardiac from a digital point of view. We are trying something really different for our general kind of medicine condition area. This is kind of the NCD area that we are also calling it, right? Like diabetes, hypertension, and so on and so forth. Here we are kind of using avatars and kind of bringing in characters in messages, right? So here you see, we have introduced a grandmother character. There's a mother, a father, a naughty kid, and we've kind of built that storyline in the messages itself. Another thing in the second image you will see here is that instead of using Hindi as a script, we are using Hindi as a language, but the script is really English, because that's really how we type on these platforms. And we are experimenting with voice, and that's what you see in the third image there, where we are asking and encouraging people to record a question through voice. That's one way we are handling some of their queries as well. Quick things we are experimenting on kind of signing up users to our service. So, from kind of building these tiny business cards, that people can quickly keep with them. Takeaways is something which we've really not seen working. People throw pieces of paper away. Posters, blink and miss them. And we are building, again, a suite of onboarding videos for both the nurses as well as the families. Quickly talking about plans for the future. So really next year is for us all about kind of improving engagement, embedding richer media, as well as kind of integrating with the government portals, right? I think one thing we were talking about earlier in the day as well, governments have their own helpline numbers. There are other organizations with their own digital services, but for a mother, that ends up being multiple services. So how can we really, build that ecosystem where the different people, players are talking to one another and really thinking about one service, from the perspective of the mother and other patients. And kind of utilizing our resources, kind of understanding our users better through the data that we get from them or through the data that we get from government databases, and really kind of categorizing them into different buckets of risk, and then kind of, deciding what kind of an intervention does a particular risk bucket needs. And that's kind of personalization at scale that we're really excited about. And finally, the evidence that we've collected, we want to continue collecting more. So far what we've collected is in conjunction with our in-person intervention, but we really want to kind of isolate and see the impact of the digital solutions going forward. Yeah, it takes a family. Thank you.